Good morning, everyone. Nice to see everyone here on a misty, rainy Wednesday morning. Spring is coming, I promise. It will be here eventually. That's what I keep telling myself. But welcome to Grand Rounds. My name is Rebecca Muley. I'm one of the Grand Rounds co-directors, along with Dr. Alex Harris and Dr. Adita Lati. Dr. Alex Harris will be our remote moderator and will be reading the questions to me online. And next week's Grand Rounds, Simon, if you can go forward just one slide, or maybe that's me. Oh, we'll go here. We have our very special presentation that is sponsored by the Office of Equity, Diversity, and Inclusion in honor of Black History Month, Dr. Pamela Collins, the Bloomberg Centennial Professor and Chair of the Department of Mental Health at Johns Hopkins University. She will be presenting a talk titled Integrating HIV and Mental Health Care for Adolescents in Kenya. And I should say that this is a very long overdue welcome to Dr. Collins because she was scheduled to speak to us last year. If you can remember back that far, that was when we had a whole different discussion about being able to support our Grand Round speakers and coming here. And we deferred her visit with us until she could actually come in person. And so we are so pleased that she was able to come back and celebrate Black History Month with us. And she will be speaking in person next week. I also want to highlight Dr. Amy Kilborn, who will be speaking the following week, the first week of March. And I'm highlighting the Grand Rounds calendar QR code that's up there. And also just want to point out that if you would like to speak with any of our speakers that are coming up, please do let us know. We don't control the calendars of all of our speakers, but we do know who is controlling the calendars. And so we can put you in touch with those hosts if you would like to speak or meet with one of our speakers. And so before I'd like to introduce Dr. Mufson to introduce Dr. Lau, I just want to remind everyone, please use the Q&A feature, not the chat. Surprisingly, we still have to say that. And if you are a trainee, please do put trainee in your question online. We also hold a space for trainee questions here in the auditorium. And because we're psychiatrists, we can wait you out through the silence. And finally, I'd like to welcome up Dr. Mufson. She is the Viola Bernard Professor of Medical Child Psychology. And she was formerly the director of the Division of Child and Adolescent Psychiatry. Associate director. You were interim director for a bit of time while, yes, she's saying that I'm trying to not be in denial about that phase. But recently you became emeritus professor status? No, apologies. But took a step back from the administrative duties and have dived into the research side of things. And we're so happy that you are still engaged with our fellows and your research. And we're very pleased to have you now introduce our speaker for today, Dr. Laura Mufson.
Thank you. That was a very fast pathway to emeritus. It's great. I would like to start out today by just sharing a little information about who Dr. Viola Bernard, for whom this Grand Rounds is named, a little bit about her before I speak about Dr. Lau. Dr. Bernard was a prominent New York psychiatrist and psychoanalyst who was on our faculty here at Columbia for 5 decades. Throughout her professional life, she worked to tackle the social problems that she saw as negatively impacting mental health. And she was one of the first people to really focus on the social determinants of mental health, recognizing early on the importance of environments and lived experiences for mental health. She was committed to understanding the needs of children who are suffering due to poverty or other social and community factors. And she was focused on targeting those factors to increase access and improve mental health care for children and families living in communities that were historically underserved. We were very fortunate, the Division of Child and Adolescent Psychiatry, that in 2016, the Viola W. Bernard Foundation made a generous gift to the division to establish this endowment fund, which supports a yearly Grand Rounds presentation, as well as opportunities for clinicians to obtain training in empirically supported treatments for children and families. And Dr. Lau also was scheduled to come here last year, when things were a little bit different in the department and she wasn't going to be able to come in person. So we were happy that she was still available to make the trip from California to speak today. So it's an honor to welcome Dr. Lau as our Viola Bernard Grand Round speaker. As you will hear, her work embodies the same commitment to ensure that minoritized communities have access to cultural and evidence-informed interventions and support for healthy development. Dr. Lau is a clinical psychologist and professor of psychology and associate dean of inclusive excellence at the University of California, Los Angeles. She received her undergraduate degree in psychology from the University of Toronto and her PhD in clinical psychology from UCLA. And with a short trip to San Diego for some additional training, she's been at UCLA ever since. Dr. Lau's translational research on risk and protective factors for youth and immigrant families and her identification of racial disparities in youth mental health services have informed her efforts to adapt and implement evidence-based interventions, looking across multiple approaches, including CBT and mindfulness and other interventions in community settings to promote equity. Her lab at UCLA is called CARE, which stands for Culture and Race Ethnicity in Youth Mental Health, which I really love the title of your lab. And her research has been supported continuously by NIMH, including an NIMH Merit Award. And her projects, among many, include addressing disparities in school-based mental health services, Safety A in schools to reduce racial ethnic disparities in mental health service use following identification of suicide risk in youth, and the Four Keeps project, which is examining how community therapists meet the needs of racially diverse youth within a system-driven implementation of evidence-based interventions in child mental health services in Los Angeles County. She's won numerous awards for her research, mentorship, and service to her university. Most recently, she received the NIMH James S. Jackson Memorial Award for her work, which this award honors outstanding researchers who've demonstrated exceptional achievement in minority mental health and mental health disparities research, community engagement, and mentorship. Dr. Lau is also active in professional societies and served as past president of the Society for Clinical Child and Adolescent Psychology in 2022. We are very excited to hear your talk today titled Harnessing Services, Intervention and Implementation Research to Advance Youth Mental Health Equity. So let's welcome Dr. Lau.
Hi, good morning, everyone. I really appreciate those of you who are here in person and online. I realize I have terrible timing. Happy Lunar New Year, Gong Hei Fat Choi. And hi to the parents at home with your kids with the New York schools on holiday. So thanks for being here. And I really want to thank the Ground Rounds Committee and Laura for the kind invitation and the hospitality. It's not lost on me that you're still giving a platform and a voice to people doing work in mental health equity and in an inclusive science of youth mental health. I think that's fantastic that you continue to stand by that mission. Even though I think we all know your institution has been under a lot of scrutiny and stress. So I'm really happy to be here and thank you for the invitation. I have no disclosures to talk about. I was really pleased to talk to the T32 fellows yesterday about kind of my journey and trajectory, engaging in research that spans services epidemiology, intervention and community-based randomized controlled trials, and more recently implementation science. As well, I've been doing work in prevention science, which I would not characterize so much as effectiveness research, but as translational and reverse translational research. So I'm going to try to talk about how these things fit together in my mind and how they've informed each other and my motivation to do this work. All of the work that I'm going to talk about today is very much community engaged. I'm not someone who does community-based participatory research that's really, kind of following the main lead of my community partners, but we really are jointly developing a focus and each informing the work. So I'm happy to talk about that my philosophy on that more. And I hope that what we can reflect on together today is the question of what is gained by redesigning service systems and interventions for equity. What is gained not just for specific populations that experience disparities, but for the population at large, for all groups. And that's something that I think is really an important message in today's climate where this work is being devalued. So I'm going to talk about the research not in a real chronological way, but I'll first talk about services research and go back quite a bit in work that helped me learn how to not just document disparities, but generate explanations for what might be driving those disparities in service receipt in communities. And then I'll talk about how that flowed into some of the school-based mental health research that I'm doing that is both intervention and implementation focused. And then I'll end by talking about some work in prevention science that we're focused on now. So in my title, I didn't highlight Asian American mental health or Asian American youth needs in particular, but I really think a lot about this lens of why my work has at times centered Asian American mental health disparities and why it hasn't. And I talked about that a little bit yesterday with the fellows. But I wanted to share with you all this paper that I think is very powerful by a former postdoc of mine, now on faculty at the University of California, Irvine, Jackie Kim, where she really talks about, as you may know, there have been some analyses of NIH expenditures over the last 20 to 30 years, noting that less than 0.2% of NIH health and clinical research was focused on Asian American Pacific Islanders. And this is in the context of their population representation being about 6% of the population. And Dr. Kim really talks about how the model minority stereotype not only affects individuals and their development and adjustment, but also permeates society in structural ways. This perception that Asian Americans are doing really well or very successful and socially mobile also kind of confers the perception that they don't have mental health or health problems. And she argues that this has largely veiled Asian American health issues and needs and has impacted funding for health research focused on this population. And as a result, there is an inadequate representation of investigators who are focused on Asian American health and mental health research, limiting opportunities and opportunities for mentorship in this area. And I think this is an important lens. It has impacted my work, and I shared with the fellows yesterday that all of the research that I'm going to talk about today, none of it was funded to focus on Asian Americans, but it has very much been motivated by our observations of service disparities and mental health disparities facing this population. So I was really fortunate to train with the late, great Dr. Stanley Hsu when he was a professor at UCLA in the beginning of my graduate program. And as you might know, he was really a pioneer in studying, using services epidemiology to study mental health service use in Asian Americans and other racially minoritized groups. And this research, he really had to kind of use administrative data that was available to sort of generate information about these health service disparities. And all along the way, he really had to counter this narrative that Asian Americans actually don't have mental health problems. And his first data, he used data from King County, Washington, the area that encompassed Seattle, and really showed that Asian Americans utilize mental health services at far lower rates than their representation in the community catchment area. And this finding he was able to replicate in many regions of the country and in very different service systems like college counseling centers. And this underrepresentation he held up as evidence of underutilization or poor reach of publicly funded mental health services. But of course, with the lens of the model minority stereotype, the common pushback on that was actually they're not in services because they don't need services because they don't have mental health problems, right? And it became circular because there wasn't any community epidemiology on rates of mental illness among Asian Americans. So they continue to use administrative data in these ways, but without that population prevalence data, this continued to be an issue. They conducted other types of services research, David Takuchi, showing in many studies that Asian Americans who do present in mental health services exit earlier, most commonly dropping out after a first session. And Sumi Okazaki did some really nice qualitative timeline follow back to show that there's a very protracted treatment delay among Asian Americans before they get care for serious mental illness, which of course really complicates their ability to benefit from treatment. And then it wasn't until the mid 2000s when we got data on Asian American mental health need from the collaborative psychiatric epidemiological surveys showing that Asian Americans indeed had high rates of unmet mental health need given a confirmed diagnosis. So all along, there was really kind of this no, there's no need, right? And the evidence was really direct, indirect. Then, I was able to pursue postdoctoral training focused on youth mental health services. And then we were really able to show that Asian American mental health service disparities that we observed in community systems, including education, child welfare, juvenile justice, and specialty mental health, were not attributable to lower levels of symptomatology, um, uh, uh, fun, uh, functional impairment, or things like access barriers like insurance coverage. Our data noted that unmet need appeared greatest among Asian American youth who had immigrant parents, pointing to some probably some mental health literacy and other access barrier issues there. And then we really showed that disparities in care differed by problem type, and it was Asian American youth with internalizing problems like depression and anxiety who were the least likely to receive care in these community systems. And even then, sort of the narrative was, well, internalizing symptoms are less severe by nature. They tend to be accompanied by lower levels of academic functional impairment, for example, and maybe this is why kids aren't turning up in care. And so maybe these patterns of use make sense. And maybe it's all about, families don't want treatment. We then continued in this area of research, now getting really concerned when we documented that unmet mental health needs persist when suicide risk is identified among Asian American youth. And we saw this in school-based mental health, and we saw this in community safety net systems. So a couple of trainees of mine, Belinda Chen and Dr. Joyce Liu, examined data from the Los Angeles County Mobile Crisis Response System. It's like PET teams who respond to youth who are in psychiatric, typically suicidal crises in the community, and reported that Asian American youth were far less likely to get follow-up care in the system following a field response to a psychiatric emergency. And we learned that the majority of those calls for this emergency crisis response originated from schools. So Asian American youth had lower odds of receiving any outpatient therapy after a crisis response, lower odds of receiving what might be a dose of psychotherapy you might consider minimally adequate. And we learned that the majority of these mobile crisis response calls were being originated at schools. So it was school personnel, noticing and worrying about a student with suicidal thoughts or behaviors, and then deploying this safety net system. I've been doing work in schools as we call it the de facto mental health system for kids. This is where most American youth receive mental health care, is in school systems. And schools are a great venue to provide mental health care to young people. Because there are fewer access barriers, and there are ways to fund these services that don't require health insurance in many local educational authorities. And we know that racial disparities are reduced in schools versus specialty mental health clinics for youth with depression, with conduct problems, and with suicidality. But our work has also shown that Asian American youth are less likely to receive mental health services in schools, controlling for levels of need. And we also found that Asian American students who were identified at school with some level of suicide risk were half as likely to get care, and their caregivers were 3 times as likely to refuse mental health services after suicide risk was identified. I should say that the comparison group in this school district is Latino youth. So another immigrant population where there are some similar issues around mental health literacy and probably some shared concerns around stigma. And when I present these data, particularly the data on Asian American parents declining referrals, I get a lot of, how could any parent deny care for their young child, especially with something as critical as suicidal thoughts and behaviors? And people go pretty straight to a cultural deficit model. It's shame, it's stigma, it's they don't understand or they don't care about their child's emotional distress. And that's a pretty common, I think, point of view and reaction. And it's harder for people to take a step back and think about some of the structural and contextual factors that may be behind this. So our team has done a lot of community partnered research with one particular medium-sized school district in the San Gabriel area of Los Angeles County. And this is where we first sort of noticed these disparities and started partnering together to figure out what was going on. So we conducted some mixed methods research on what happens when young people in schools come to the attention of school personnel because they have suicidal ideation or some self-harm behavior. And we did some qualitative interviews with various stakeholders, including students and parents with lived experience of having a school-based suicide risk assessment, and with school personnel who are tasked with this task of assessing kids' level of risk and determining if there needs to be an emergency services deployment, and then furnishing and trying to link families to care. So we learned a lot that helped us understand what we were seeing in the drop-off and care receipt after. So, in talking to students and parents, it was very common that this was their first encounter with any kind of mental health services or any mental health counselor or any first discussion of their young person's mental health. Um, Students, a common scenario might be that someone told a friend or a peer that they, you know, uh, had thoughts of death, or no one would care if they were here tomorrow, kind of thing. And they come to the attention of someone like a school counselor. They get brought into something like a vice principal's office. And they get asked a lot of questions about their suicide risk, because the job number one is to figure out if there's imminent risk. A lot of those questions are very detailed, repetitive. You might have 2, 3 people come in and ask you the same question to see if your answers change. And students felt like they were in trouble. Um, they experience things like personal searches and bag and locker searches, where the school personnel might put on latex gloves and go through their backpack looking for sharps or other things. They are told, we're going to call your parents have to come in. And when the parents did come in, they were, told, your child is maybe having suicidal thoughts or plan for attempt. We are going to transport them to the hospital. Very common that they might, school districts have different protocols. This might be a school resource officer putting a kid in the back seat of a police car. Sometimes there are protocols to zip tie kids' wrists to protect them and keep them safe. Sometimes they're deploying those county PET teams and psychiatric mobile crisis response teams, and kids go to the hospital in an ambulance, and maybe their parents follow in a car behind. They go to the ED typically first, because there are very few psychiatric EDs. So they go to an emergency department and they wait and they wait and they wait. Very rarely, actually, are they ever admitted. But then someone there goes through the same screening questions. And by this time, the kid is like pretty sure how they should answer. And they deny active ideation, and they get sent home, is typically what happens. But as you might know, this can be a very long wait. It could be overnight. Sometimes, actually, they are assessed as in some type of imminent risk level, but there's no bed, so they're still sent home with really no meaningful crisis intervention. And for most families, again, they have not had any prior experience with any kind of health services for a mental health concern. So those experiences are really pretty traumatic, or maybe re-traumatizing if a youth has had a similar experience with a coercive system before. If they are placed on an involuntary hold and hospitalized, for many kids, this is their first separation from their family, and it's a 72-hour hold. So to me, it's no surprise that what happens after an acute response like this is that parents tell the kids, do not talk about your feelings at school. If you are feeling hurt or whatever, depressed or despondent or hopeless, just do not talk about it, especially not at school. And there is no way you're going to see a therapist, because this is what's going to happen again. So these qualitative data are kind of really important, right, to help explain why we see, such a high rate of refusal of referrals afterward. When we talk to school staff about what it's like for them to implement a protocol around suicide risk assessment, we know that school staff really like having an unambiguous step-by-step protocol to follow. They really do not want to incur any liability, right, for saying that a student is safe to go home and, God forbid, something happened to that student. They don't feel like they are well trained, right, to make any decision about that risk determination. And so it makes complete sense, right, that they are going to kind of transfer that liability onto a tertiary care system. Many of the people who's have it in their role in the schools to do suicide risk assessments are actually not mental health trained. They might be an academic counselor, meaning the person who gets you your classes for graduation to make sure that you are meeting graduation requirements. It may be, a school nurse, which is better, but that doesn't have a mental health training, might be a vice principal, can be any number of non-specialist folks doing that work. And of course, when we talk to them, these are people who have like committed their career to young people. They want to do right by youth, but they're really in a tough situation to do so. We developed a plan to implement an evidence-based trauma-informed strengths-based intervention and to deploy that in schools in this context of schools having to do this work of assessing youth for suicide risk. So I'm going to shift then into implementation research that was really kind of a direct result of this service disparities that we observed in that kind of school-based mental health services research. So the context in California and in most states is that LEAs, local educational authorities, have typically some sort of legal mandate to make sure that they have a protocol in place to respond to students who are in crisis. In California, what that looks like is every school board has to approve a protocol. There isn't a statewide kind of a system. Everyone's kind of doing their own thing. And as I mentioned, students are often revealing suicidal thoughts or behaviors to an adult for the first time at school, and parents are typically very much surprised and caught off guard by this. And the current approach that we just talked about, caregivers, students, and providers are really dissatisfied with protocols, and we have these racial disparities in linking youth to care. My wonderful colleague, Jonah Sarno, who many of you I think know, developed an intervention called Safety A. I'm going to forget what it stands for. Safe Alternatives for Teens and Youth Acute. That's what it stands for. And it's a brief family-based intervention that has been shown to enhance linkage to care for youth presenting in the emergency department, which is great, right? And she's got a number of controlled trials and some ongoing PCORI-funded work to really scale this up in health systems across the country. And the main goals of this, you can think of it as a single session intervention, are to assess risk, to build hope, to foster connections with caring and responsible adults, and to develop a plan to keep the young person safe. We reanalyzed Joan's data in advance of this trial and showed that in her original emergency department study, the benefits in increasing the rates of linkage to care were all driven by a youth of color. So in her studies in the 2 hospital settings that she looked at, if you were a white kid, you were going to get care after your ED visit no matter what. But if you were a youth of color, Safety A really increased the probability that you would be connected to care in the follow-up period. So a typical implementation problem is to take an intervention that was developed and used in one type of service context and adapt it to fit an entirely different service context and oftentimes a different community of recipients or families and children. So that was our task in this R34 funded rollout implementation optimization trial, and I'll talk a little bit about what Arroyo trial design is. But I really never wanted to do suicide prevention research. It's not my expertise. But this was very much driven by the community partnership, and I really needed a lot of support from the experts. So David Goldston and Jonah Sarna were really essential in this trial. And then I was really fortunate to have two amazing postdocs who actually were trained by Joan in Safety A come and be trainers and consultants on this trial. So Silvana Vargas and Prerna Martin. So we used human-centered design methods to adapt the intervention itself. Because we were in school districts, 4 school districts that were primarily serving immigrant communities, we really wanted to make sure that the interventions we were bringing in that really focus on mobilizing family support and communicating with parents and youth about mental health, typically for the first time, that was sensitive to the context of families with a different cultural background, different mental health beliefs, different styles of family communication. So we did some cultural adaptations to the intervention itself, and then we deployed a number of implementation strategies to try to make Safety A fit the school setting. As I talked about before, people who do suicide risk assessments in schools are often not specialty mental health providers. They need different types of supports in learning a complex behavioral intervention. And so we adapted both the intervention materials themselves and then the implementation strategies to train and support providers in doing this. So our AIM 1, we used interviews and what we call theater testing to describe Safety A and get impressions of acceptability, feasibility, and any needs for adaptation from school providers, from caregivers and students with lived experience with suicide risk assessment in schools. We worked up an initial set of adapted materials and further iterated on them in focus groups to refine. And then we developed a set of trauma-informed adaptations. And where we were really focused on was promoting trust and collaboration with families, particularly families that have had negative prior experience with systems, coercive systems. Some themes that were identified by stakeholders that could impact our ability to implement Safety A in schools with our target communities were these cultural differences and immigrant family processes, prior history of system over-involvement with communities of color, and some learned mistrust with systems. And then, of course, our implementation strategies were to address these sort of inter-system reliances, so reliances on police and child welfare and tertiary care systems, working with our school providers to understand those, how families experience those interagency linkages. And of course, to address the resource, time, and workforce constraints in schools. So some of the intervention adaptations really helped providers understand the context of how to communicate with families about the student's suicide risk and acknowledging the wide variation in how families communicate or not about children's emotional distress. Teaching them and understanding them, trying to raise awareness of what an acculturation gap is. This is the notion that children in immigrant families acculturate much more quickly to sort of American host culture and understandings of mental health, ways of communicating around emotion, whereas immigrant parents tend to acculturate much more slowly to some of those processes. So meeting families where they are, acknowledging and validating all the ways that parents support their children when they are in distress, and that might not be sitting down and talking about feelings, right? That might be physical touch or comfort, favorite foods, distraction of shared enjoyment. and really validating that parents can provide support and protective monitoring in ways that align with how their family already supports each other. Um, as far as the implementation strategies, we really had to do this district by district to develop their implementation plan with their district leadership, making sure that we aligned everything about the intervention with their school board approved policies for risk management. And meeting their provider workforce where they were in terms of their need for training, consultation, and education. So we had the usual set of, we do an initial workshop, and then we had a semester-long consultation model where our expert trainers would continue to meet with and troubleshoot implementation. We also had leadership coaching. We identified peer champions. We did a lot of positive reinforcement of any kind of adoption of the intervention that we could see. And then we helped districts plan for sustaining the practice after the trial end. Some of the trauma-informed practices that we that were already part of Safety A that we reinforced were transparent communication, shared decision making, making that really clear in our manual how to do that. Embracing youth and family strengths first. Again, meeting families where they were, and really all with the aim of fostering trust between the school providers, students, and caregivers. We strongly encouraged the de-implementation of bag and locker searches and instead helped providers understand how to do that within a collaborative model of lethal means restriction. So to walk alongside the caregivers and the students about, what unsafe objects need to be put away, and have actually the young person go through their backpack and locker when possible. It became important to us. This was not a study aim initially, but it became important to us to reduce unnecessary transport to hospital. And this was really delicate, right? Because it was asking schools to incur liability in a sense. But we also had a lot of dialogue around this because a lot of school districts were actually exposing themselves to a ton of liability by not having a clear protocol for how to assess risk and support families in keeping their students safe. Because we know that sending a kid to the ED, they actually are very unlikely to get any supportive crisis intervention there. So we really got people to de-implement what was their prior reliance on doing a brief Columbia screener and then calling the emergency transport right away. So what this trial looked like, and I was Randy and I had decided one should never do this again in an R34 to have 4 school districts in a pilot trial. But this did give us was it gave us the opportunity to use what's called a Arroyo design. So to implement in one district first, learn from that implementation, and continue to iterate on the implementation strategy and the intervention so that by the time we got to the end, we understood the various types of school district contexts, what their needs were, and to build out some of those supports that different districts needed. We ended up training 226 school-based providers who worked in 90 schools across 4 public school districts. The school districts were kind of across Southern California and in really different neighborhoods, some primarily Asian American, Pacific Islander neighborhoods, and some more almost exclusively serving Latine students. And this, again, really gave us an opportunity to really observe how some of the adaptations to the intervention played out in very different communities with different, actually, historical relationships with law enforcement, child welfare, and specialty mental health care. So that was another great thing. These are student level data we ended up observing, what's the total? A lot of suicide risk assessment encounters, too many. Schools were doing this easily weekly. A typical high school would have multiple suicide risk assessments. This period was immediately post COVID. It was during what I would say sort of peak youth mental health crisis. We blew our enrollment milestones out of the water in a really unhappy way, right? So much data. 192 of these encounters were with Latino youth. We did get some data on the semester after the implementation period in the first 2 districts where they were sustaining the intervention. So some findings. So it was very hard to consent youth into this trial. We felt that did turn out to be feasible to collect research assessments with the kiddos. So all of our data are from administrative data that were captured during these encounters by the providers. So at the beginning of the safety A encounter, there are 3 questions that Joan uses to assess risk. They rate their urge to harm themselves, they rate their feelings of hope, and they rate their confidence or self-efficacy in staying safe. And we found medium to large pre-post, the beginning to the end of the session, effects in de-escalating kiddos, which was really nice. And then I would say we also took a QI or quality improvement lens to see what was happening in practice in suicide risk assessments in these schools. And we showed multiple really great changes in routine care. So we showed that districts increased. There were some districts where if they determined that risk was minimal, they never contacted a caregiver about what they learned about their child or that they assessed them for suicide risk. So we changed that in 2 school districts. We had 2 school districts that, weren't doing safety planning routinely. We improved that. And then in 3 districts, we reduced rates of transportation to the hospital, which we were really glad to see. As far as provider implementation outcomes, they really were ceiling on feasibility, acceptability, and appropriateness quantitative ratings. We did observe a lot of variation in adherence to some of the components and across the districts. And our qualitative analysis is really showing how vital the implementation leadership is in this. So having district leaders that stood by and supported providers in doing this work was really essential. And we also found that providers reported increased self-efficacy in their job and trust and collaboration with the families they served. So these are just some of the changes we observed in some of those quality indicators and some of the reductions in emergency transport to hospital, which we feel like are really important. So I'm gonna skip this because I bet I'm taking too long. And I'm gonna skip this. Our next steps are really to think about one of our primary outcomes that we wanted to move was the rates at which we were able to link kids to care afterward. And we found in this time and place, we really weren't able to budge that outcome because community services were so tapped out. And we just ended up, getting kids to agree to go on a waiting list. And that wasn't really helpful. So really, we're thinking next about how can we continue to profit from the good work and this family-centered, trauma-informed intervention that we're doing with families in the schools at the acute event and support families and youth to use their personalized safety plan to kind of continue to understand their triggers for suicidal thoughts and to use cognitive behavioral strategies in a short-term stabilization period in the school. So that is our next community partner direction. Doing this work, I'm just going to, I see that I'm running out of time. But it's a bummer to work the tertiary services end of things to see kids when the needs are so acute and when they didn't get any early intervention. So, we also have been doing prevention work in the schools and, studying risk and protective factors for internalizing mental health problems in Asian American youth in the schools, then selecting evidence-based intervention that can be targeted or adapted to target those mechanisms, and then deploying community-based trials to, contribute to that evidence base on evidence-based interventions, then, taking those and trying to scale them up, of course. But this prevention research also gives us an opportunity to really, use an experimental strategy to test questions about what we think are mechanisms that drive risk. Especially for me, my interests are in really understudied groups like Asian American immigrant youth. So I'm going to skip all of this because I'm really too slow. Okay, but I'm going to skip a lot of it. Okay, what I'll say about this is we did some work on what are risk factors for internalizing problems among Vietnamese American youth, actually, in schools. And that data really pinpointed, things that weren't too surprising. Interpersonal stress, particularly related to parent-child acculturation gaps and the types of both distancing and conflict that can occur in families where there is kind of a cultural gap between generations. We also identified emotion suppression coping as very common among Asian Americans and related to internalizing distress. Even though we also had some data showing that the prospective associations between emotion suppression were somewhat attenuated for Asian Americans relative to other groups. So this is sort of the cultural normativeness hypothesis. It is thought to be culturally normative to push those feelings way down in service of, kind of keeping harmony, not drawing attention to yourself in interdependent East Asian cultures in particular. So there are questions about should you mess around with that if it is culturally kind of syntonic, and maybe if it doesn't have as strong a relationship with something like depression or anxiety? So this was really, a question that vexed me for a long time, right? Like, can we use our evidence-based interventions that target something like emotion suppression and expect the same benefit in a group that has cultural differences in emotion regulation? So those were some of the questions that we looked at in this relative effectiveness trial, where we took an intervention targeting interpersonal stress. So that's actually IPT-AST in the schools, and mindfulness-focused intervention that really targeted emotion suppression coping. And we did this in primarily Asian American Latino youth school districts. And what we found was, to back up a little bit, this study was also looking at what happens if you let kids pick which intervention they want. Do they do better if they get their preferred intervention? We found zero signal of a preference effect. But in this study, we actually found a strong intervention condition effect where kids benefited more from the mindfulness intervention targeting emotion suppression compared to the interpersonally focused intervention. And the good news for us, too, was that in our context, the mindfulness intervention was much more scalable. Classroom teachers could deliver it. It only had group sessions and not a mix of individual and group sessions. And this sort of led us to focus more on mindfulness interventions in the schools, showing that they were effective for Latina and Asian American youth, and regardless of values around emotion suppression coping. We also now have gone to using our prevention trials to ask kind of more basic questions about things like emotion regulation in the context of mental health and health disparities. So mostly people do bench to bedside research where you're identifying risk factors to target an intervention, and then you're doing a clinical trial to test that intervention. And we've started to do work where we're trying to actually use controlled trials to ask questions about mechanisms. And I'll illustrate that a little bit now. So, we are conducting a mechanistic prevention trial now where we are looking at high achieving students of color. Our sample is all Asian American and Latino students primarily. They are in schools serving low income immigrant communities. And our inclusion criteria is that they're high achieving. So they're in a top percentile band of GPA in their schools. And why are we focusing on this population? You might have heard about a concept of skin deep resilience, this notion that academically resilient, disadvantaged youth, they look really resilient. And then if you look under the skin, you can see higher rates of cellular aging, higher allostatic load, that there's something about what it takes to be socially mobile, to be high achieving, to be academically resilient in the context of risk that is costing something to their health. And so we are really interested in this notion of costs of resilience and what are the self-regulation strategies that promote resilience that might fuel health and mental health disparities. And we're using a prevention trial to see if we can interrupt the link between academic resilience and poor health outcomes. When I go to schools to tell them about this trial, I tell them things like, we have now data that Black and Brown youth who rise out of low income family contexts to middle and professional social class tend to show worse health outcomes than their counterparts who are not socially mobile. And we get this unevenness in the SES health gradient, where social mobility confers better health in white populations and not so in minoritized populations. I see people nodding their head. There's some costs here. So we're in this vein of trying to understand this and actually trying to interrupt that with a focus on individual level health promotion. So, what might this look like? You have families raising kids in the context of structural disadvantage. They socialize their kids around how to manage their emotions in this context, how to achieve despite barriers. And also, some of the racial socialization messages are you've got to work twice as hard to get half as far, right? So, people are getting these messages about it's important to be strong. We're all counting on you, and hard work. And we think a behavioral phenotype that can emerge is, really, it's good to suppress your emotion because you got to kind of keep plugging away and do your work and keep doing your work. So that is where we think, can we intervene? Can we intervene in this self-regulation style that we think might be responsible for health disparities that emerge later in life? So that's where Project Strive comes in, where we're trying to intervene on what we're calling a striving persistent behavioral style that leverages emotion suppression and what we're calling unmodulated perseverance, sort of John Henryism, you can kind of imagine. And we're doing this work in school districts. And I tell you, we are done with enrollment. We enrolled faster than any depression prevention trial I've ever had because inclusion criteria was high achieving. But internalizing symptoms were just as high on average than when I recruited kids who had internalizing symptoms. They're the same kids. And, it was easy to recruit schools into this trial. It was easy to recruit kids into this trial. So we are now fully enrolled. We enrolled 504 students in 3 cohorts instead of 4. We are collecting allostatic load data in the field, which is really hard to do. And we are really fortunate to have an opportunity to get non-competitive renewal in 5-year increments. This is the Merit Award R37, so that we can follow these young people into adulthood. And again, this is to test that question of, I might, as a psychologist, not in a position to directly address these upstream contributions to health disparities. But is there something that we can do that's ameliorative at the individual level that helps us understand, why do we have this unevenness in the SES health gradient? And I will just acknowledge the many teams that contributed to this work, and my colleagues and community partners, and all the support, both project-related support and training support for all the trainees who are learning how to do this work on these projects. Thank you so much.